share the European perspective and the British perspective, we invite Dr. Gini Giampaola, a good friend from EVRS, to share his experiences on the European perspective.
And
he will be introduced by Dr. Andres Rosolo. Sorry.
No, I was in China in December when the COVID was going on, and in January in Singapore with Gangadhar, and in February in Jakarta. And Giampaola is a very old friend and president of the European Vitreoretinal Society.
Thank you. As Dr. Natarajan informed, he's also the vitreoretinal consultant at Western Sussex NHS University Trust at Sussex, United Kingdom. He's also a vitreoretinal consultant at San Marco Eye Center in Florence, Italy, the president of the European Vitreoretinal Society, the American Society of Retina Specialists Vice Liaison Officer for Europe, and a board member of the Italian Society of Ophthalmologists. Dr. Giampaola, the floor is yours. Thank you.
Thank you. Thank you very much. And again, a special thanks to the organizing committee. They're all good friends. Some are new friends, some are old friends. And I wish APOTS the very best. I'm very honored to be here today, and I believe that what APOTS is trying to do is leading the way into a new care of ocular trauma, and it should set the example for many other societies throughout the world. Now, Professor Wah has wonderfully illustrated many details of how to handle these patients. So I would just try to touch on some other aspects which are more typical of our continent, that is Europe, because I believe that we do have differences as well as similarities. The differences are obviously due to culture, they're due to geographics, and they're due to obviously also political and economic factors. So let's see what has been happening here. As you know, I work both in the UK as well as in Italy, so I have a lot of friends that have been good enough to share their experiences with me, and we have combined our experiences to give you this talk today. When this is a today, controversial the greatest risk video, of global catastrophe doesn't look like this. Instead, it looks like this. If anything kills over 10 million people,
sorry, can you share your screen?
It's most likely
to be a
highly infectious virus.
Excuse me, Dr. Gini, you need to share your screen with the green button down below.
Oh, forgive me.
Don't worry.
I thought I had done that. Right, trying to get around to it. Okay, let's see. Can you see me now?
No, can't see you yet.
There you go.
Can you see it now?
Oh, we can see the banner, not the video yet.
That's not what we want, is it?
So, Professor, what you can do when you go to share screen, first of all, you select on your laptop whatever you wanted, and it should be there on your screen, and then go to share screen option, because sometimes it will choose something else.
So right now I have shared my screen.
No, stop sharing now. First stop sharing and again reshare. So stop now.
Okay.
And then go to your desktop, whatever your presentation is or whatever video is that. Click it, and it should be there on the desktop there. And then again go to share screen and then share that.
If you want to work in the background, we can move on to the next presentation and then we can come back to this.
It probably is best to do that. I don't want to take up anybody's time. So shall we do that?
Maybe if you hit the green button over there, it will go full screen. Top left of the video, click the green circle, and then play. O reproducir.
It says that it says that I'm sharing, but it doesn't seem to be.
Don't worry. There you go.
Yeah. There you go. Perfect.
Can you see it?
Now,
Yep. Now you can.
Full screen.
Okay.
Play.
Is that it? We got
That's
it? Operational? Good. Okay, so this is a controversial video. Some people like this gentleman, some people don't.
Today, the greatest risk of global catastrophe doesn't look like this. Instead, it looks like this. If anything kills over 10 million people in the next few decades, it's most likely to be a highly infectious virus rather than a war. Not missiles, but microbes. Now,
so I think you heard those words from Bill Gates, who was a very controversial figure, but he certainly did say something interesting back in 2015, but he obviously did not have a particular insight apart from history. History has shown us that we have had a number of epidemics which have accompanied mankind throughout history. We all know about the Spanish flu, which killed a great number of people. Some say 80, some say 100 million. But from the beginning of mankind, there have been plagues of all sorts. From Justinian's plague, I was researching back in 540 after Christ, half of the world population was wiped out. The Black Plague in the 14th century took care of another third of the population of the world in those days, and we've had many other similar occurrences. So it's nothing new, and I would say that we've always dealt with epidemics in the same way, basically by distancing, by you can see the nurse here in the 1968 epidemic when hospitals were closed down. So I think that we have seen this happen before. Now, the World Health Organization was actually preparing for such an event, and it pointed out as the number of epidemics was growing throughout the world, how the world should prepare and more coordinated efforts should be made for state agencies to share data, prepare for an epidemic. Unfortunately, this has not happened. And when the COVID virus hit in early 2020, the world was simply not prepared. So we know that on a timeline, we had obviously the first cases reported by China at the end of 2019. And then they hit Europe in the early months of 2020. And Italy in Europe was the first country and one of the first in the Western world to go on complete lockdown, and that was on March the 8th. After which the World Health Organization, after a few days, declared COVID as a global pandemic. The lockdown lasted in Europe until around June. There was some easing after during the summer months, and then again we hit a second wave, which is now climaxing, especially in the UK, which has come, as you know, to a lockdown. We are now in the highest possible tier level, which is tier number 5, which we'll talk about in a few minutes. So how did the epidemic actually, what effects did it have on the health system? Well, essentially, it created an unprecedented number of acutely ill patients, and this created capacity issues not only in the intensive care units, but throughout the whole hospital system. So many departments were either converted to COVID units, or they actually could not carry out their normal work because of fears of contamination. And therefore, many standard procedures and much of the care, for example, for cancer patients, had to be postponed. And this obviously created huge problems. Also, many operating room procedures had to be stopped as trained staff, such anesthetists, had to be diverted to intensive care units. So what did governments do? Well, the first thing that governments did was to progressively introduce restrictive measures so as to keep the hospitals from being overwhelmed. This was done in the UK with a tier system in which you see the essentially four different tier levels, where the fourth is a clearly declared epidemic and where people are asked to stay at home. The fifth level is actually more theoretical than practical. It is where we reach a level where we believe that the whole NHS, the national health system, can be overwhelmed. So in Italy, we have something similar. It's a color-coded system where we allow people to move with more or less freedom according to the color of the region in which they live. And of course, the all-important number nowadays has been the R number, on which we base all the decisions. So the R number being the number of people that can be infected by a single individual who was actually carrying the virus. Did these measures work? Yes, indeed they did. We can see that the lockdown and the infection rates in the UK dropped dramatically after the 24th of March, when the first lockdown was introduced. So no doubt that these measures are really effective in reducing contamination. But what effects did they have? Obviously, they had, as we would say, side effects. They had a profound impact on many, many aspects of life. And these went from the economy, which has suffered very heavily, to society and social behavior and problems related to that. But also the medical practice was obviously very, very highly affected by this lockdown. So specifically, when we talk about ocular trauma, it comes to my mind how lockdown and how these restrictions have affected it. And I would put it down in essentially in four main categories. One, as Professor Hua pointed out, the delay in patient treatment. Two, the different injury pattern which we now have experienced, and someone was just talking about this before we started this meeting. And three, the need to adapt hospital facilities and safeguard staff. And I think Professor Hua already mentioned how this is done in China. And finally, the need to maintain surgical skills. And I think Gary will be talking about this because we must maintain our surgical skills, not only for ourselves, but also for the people that we have in training. So for some reason, okay. So the delay in treatment occurred because of two reasons, especially. One, the reluctance of patients to attend hospitals, which were thought to be unsafe. So if you ask people to stay home, people will be afraid of going to hospitals, and the media was responsible for some of this, I would say, misguided information. and then the rerouting of patients due to hospital capacity issues, which made accident and emergency departments dysfunctional, so that they could no longer treat minor traumas because they had eye traumas, because they had more important issues to deal with, or limited access to general anesthetic for severe cases, so that these patients could not be treated at the first hospital they were referred to, but had to be moved on to tertiary treatment centers. And this is an example which has put in. This is a young man that was doing some work in his house. He felt his eye being hit by something, didn't know what. As it turned out, it was a corneal perforating injury with this retained foreign body, which was detected only at the end of lockdown, so after several months. And you can think, obviously, of the risk which is involved with this, with the possibility of endophthalmitis, the possibility of siderosis, and all the different things that you know as well as I do. So why did this patient not come to A&E? He was afraid, obviously, to attend hospital. Looking ahead, because this is the title of my talk today, looking ahead, what can we do to avoid delay in treatment? Well, we can improve communication with the public. So the media should make it clear that that delaying the treatment in ocular trauma can have devastating results. And so people should be invited to attend hospitals because we have learned our lessons in these past few months, and we have tried to make hospitals as safe as possible. Also, this can be done through school children. School children are always very receptive. They also influence their parents very much. And even with remote teaching, as we have now, because you know that our schools are closed, this message can be introduced to the children and they will pass it on to their parents. More on this in a second. And then we can improve the coordination with primary care providers. These are the GPs, so family doctors, out of hours services, 111 in the UK, 118 in Italy, and so forth. And even opticians and pharmacists can all contribute to having the patient attend care when needed. Also, we can approach this by providing safer environmental conditions, which will make the patient safer and more at ease. So ideally, we should have independent, completely dedicated green ophthalmic structures. Now on the left is Western Sussex, where I work, and this is a completely dedicated ophthalmic hospital in line with the protocol, with the manifesto of the Royal College of Ophthalmologists, which calls for more independent centers even before the epidemic broke out, so that more specifically orientated ophthalmic services can be provided to an aging population. And of course, the third line of approach is that of using telemedicine to a greater extent to triage and counsel patients. Now, this can happen through primary care providers, but as Natarajan was telling us that they have 5G in India. As we get 5G and more advanced technology in Europe as well, we will probably be doing away with the intermediate primary care providers, and patients may address their ophthalmologist directly. Now, we have noticed, as I was saying, a different injury pattern. There has been a decrease in severe work-related injuries. There has been a decrease in pediatric injuries, although this applies to Europe. It does not apply to all parts of the world. I was reading some papers from India where they actually had an increase in pediatric injuries. There has been obviously a decrease in sports-related injuries, but again, I was hearing Professor Watt that was mentioning the fact that this is not always the case. And we have had an increase in do-it-yourself injuries because people have dedicated their time to home improvement and doing their hobbies. There has also been a slight increase in globe ruptures due to domestic falls, at least in our experience. And this may be due to mental health issues. People are tired, exhausted of being in the house all day, especially people living in apartments. I think they lose concentration, they lose a lack interest in everyday activities, they become careless. And interestingly enough, there has been an increase of about 25% in domestic violence throughout Europe. This applies to every country in Europe. The numbers are very similar. And when you're living with somebody all day in close quarters, things can get pretty tight, and probably this results in something like this.
Because of coronavirus, you are going to be quarantined, but you have a choice. Do you A, quarantine with your wife and child, or B?
Yes, I totally share this view. And so looking ahead, what can we do? Well, we have regulations on the workplace. This, especially in Europe, they're very strict regulations. So the number of accidents on the workplace has diminished. Now we need to give education at home. So people should know that they must wear safety goggles. They should store chemicals, detergents, and so forth away from children. And this can be done, again, through the media and through children at school. Looking ahead, and I'm almost finished, there are challenges, and the challenges are those of protecting staff and protecting patients. Right now, what we have in place are molecular swabs for all patients accessing our operating theaters. They're usually delivered in 4 to 6 hours, and therefore we can deal with most emergencies with a reasonable degree of safety. When this is not possible, then we move up to full PPE with FFP3 masks and visors to protect our staff. We must also work on guaranteeing access to the operating room. And Ganga was talking about this, how we need to actually work with and sometimes put pressure on the management so to underline the importance of ocular emergencies, which are not only retinal detachments, are obviously all sorts of emergencies which go from glaucoma to ocular trauma. And we must coordinate territorial resources so that more hospitals can cover a certain area and deliver, maybe coordinating the resources. Those services which cannot be given by one hospital can be given by another. I can only thank all the people that have contributed with their thoughts, with their statistics, with their experience. The members from EVRS, the members from the Italian Society of Medical Ophthalmologists, the British Emergency Eye Care Society, the Italian Vitreoretinal Society, and then my good friend Marco Pellegrini from Sant'Orsola Hospital in Bologna, who has published this interesting paper in Eye Changing Trends in Ocular Trauma. And this is a nice paper if you want to read it. It gives a snapshot of what is happening in Italian hospitals today. And of course, I want to thank all of you for putting up with me. Thank you.
Thank you, Giampaola. And I think, as usual, a very erudite presentation. And I think you covered the things happening. And I think everywhere this domestic trauma has happened. And I don't know whether you know, in India, unfortunately, the wives could not tolerate the husband. And then the wives have hit the husbands. And then I operated it's not a joke, I operated a husband whose eye was having a suprachoroidal hemorrhage, and the was there, and the eye was no PL. And he came today, and then the wife is crying. Then I said, don't feel guilty. You hurt him, but now what to do? We have to do the surgery.
But actually, men tend not to report this because of obviously ancestral heritage. But there are websites where men can anonymously sign up and report domestic violence. So we always think of men on women, but it's no longer a gender issue. It's just now widespread violence. Yes.
Now we are sharing the screen, and actually, I'm going tomorrow to a place called Nashik. It's about 3 hours from Mumbai, and there is an association called Husband Battered Syndrome. Husband Battered.
Yes. Yeah.
Beaten up by the wives. Great presentation, Giampaola, and I think thanks for an excellent thing happening in Europe between Italy and UK. Thank you very much.
Thank you.
And I think we are going to have the discussion later, right?
Yeah.